Hello everyone, this is Stephen Zuckerman in Baton Rouge, Louisiana, and the topic for today's discussion is how to enable you or help you localize where the lesion is in someone whose chief complaint is that of double vision or diplopia. And like the approach to any problem at all within medicine, we first obtain a history and then do an examination, at the end of which you should be in a pretty good position to localize to one of the oculomotor nerves, or perhaps multiple oculomotor nerves, or even some other problems which we'll discuss. So how does history help you out? Well, the first question that needs to be resolved is whether or not the double vision takes place when the patient is using both eyes, or does it persist with one eye covered? If the diplopia is present when they're using only one eye, that would suggest that the problem is ocular, either in the cornea or in the refractive media or perhaps the retina, but it is not an oculomotor problem, and so therefore those patients would most likely be best served by seeing an ophthalmologist. If, however, the double vision is only present when both eyes are being used, well, then it is within the neurological field. So the second question then becomes, are the two images separated in a horizontal, vertical, or perhaps diagonal orientation? If the two images are vertical, that would suggest that there is a possibility of a fourth nerve, trochlear nerve or superior oblique muscle. If, on the other hand, the images are separated in a horizontal direction, that would be more indicative of a sixth nerve, a lateral rectus palsy, or if the images are seen diagonally, then perhaps a third nerve palsy with weakness of the superior inferior rectus, medial rectus rather, and inferior oblique would be possible. Now, after you've ascertained whether the orientation of the double vision is vertical, horizontal, or oblique, there are a few other questions that can be used to further localize where a problem might be located, such that if there is a horizontal diplopia, the next question to ask is whether or not the diplopia is more apparent to the patient when they're looking at a distance or they're looking at a near object, such that, for example, to look at a distant object, the eyes will tend to diverge. And so if the problem is in a lateral rectus, a sixth nerve problem, or a sixth nerve problem, then that would be exaggerated or amplified when they look at a distance because divergence is necessary. However, if the double vision is maximal or more noticeable upon near vision, it would be more indicative of a medial rectus problem. Finally, you want to determine whether the diplopia is worse when they look to the right or to the left. So in which direction of gaze will the maximum separation of images be most apparent? And if you've determined that it's presumably a lateral rectus problem and it is maximum to the right, then you've diagnosed a right lateral rectus problem, conversely to the left. And if the diplopia is strictly vertical, the next question to be asked is whether or not it's worse when they look down or up. A superior oblique or fourth nerve palsy will be most apparent when the patient is looking down, and for example they'll have some difficulty navigating stairs because they obviously have to look down when they're going downstairs or when reading a book, etc. If it's maximum upon upgaze, it might be some form of a strabismus or skew deviation. This current slide is just a graphical depiction of the algorithm that you can use to approach the diplopia to determine whether or not, by history, you can isolate the problem to one of the oculomotor nerves. Having completed the history, the next step in the evaluation would be to perform a neuro-ophthalmological examination. First step of this process would entail an assessment of the afferent function of the visual system, and so you would assess the visual acuity of either eye individually and then determine whether there was an impairment in color vision, and if there was a disparity in the acuity of the two eyes, you would want to determine whether there was a possibility of an optic neuritis, and to do that you would perform the so-called swinging flashlight test, looking for an RAPD, which would be called a Marcus gun pupil, because as it says here, the presence of an optic neuritis in conjunction with any of the cranial nerve or oculomotor nerve problems or palsies would indicate that the lesion is probably at the orbital apex. And then finally, it's very important to obtain an accurate visual field determination. After having completed the evaluation of the afferent function, the next step would be to assess the efferent or oculomotor functions. This is performed by moving your finger in an H configuration slowly, such that the patient can readily follow your finger with their eye movements. It's important not to just have a configuration of a plus sign, because if the eyes are kept in the midline, then vertical movements will use two muscles, and so you won't be able to isolate whether there is a problem with an individual muscle. Now, sometimes patients may have misalignment of the eyes. For example, one eye might be deviated upwards, and that would be called a skew deviation, and it's characterized by that same misalignment is present in all fields of gaze. There also may be some horizontal misalignment of the eyes, which you would know by the performance of a couple of tests. Exotropia refers to the eyes having an outward deviation bilaterally, and you would notice that if you shined a flashlight on the patient's pupils and the center of light would fall medially to the center of the pupil. If, on the other hand, they have an esotropia, the eyes tend to look inward, and if you shine the flashlight in the eyes, well, then the light will be centered lateral to the center of the pupil. And there are also exo and esophorias, which means that it's not present at all times, and it would only be detectable if you performed a cover-on-cover test and note that the eye tends to correct itself, so that the phorias are only present when they're not using both eyes, which is termed when stereofusion is broken. Now we will discuss involvement of the individual oculomotor nerves and the expectations and associated features. So we'll begin with the third cranial nerve. So you will recognize that when the patient has complete ptosis, and when you open the eye, the affected eye will be oriented down and outward, and there will be a large and unresponsive pupil. When you see this, the important thing is to determine whether it could be an isolated third nerve lesion, because if it happens in conjunction with other cranial nerves such as 3, 4, and 6, that would suggest that the localization of the problem is more in the cavernous sinus. And if there is a third nerve on one side and a contralateral hemiparesis, that would be indicative of a brainstem lesion that's referred to as Weber syndrome. If you do see evidence of a third nerve palsy, it's very important to determine whether or not there is so-called pupil sparing, such that if there is no oculomotor nerve function but normal pupillary function, that would be suggestive of a diabetic or ischemic third nerve, whereas if there is a motor third in addition to pupillary involvement, that would represent a posterior communicating artery aneurysm until proven otherwise. A fourth cranial nerve palsy will present with a vertical diplopia, and you will be able to note that the adducting eye is unable to look downward as well as its other eye. The most common causes of this will be either ischemic, so you can ask about a history of hypertension or diabetes, or traumatic, but at times patients may have had a congenital palsy which they had previously successfully fused images in the past, but they lose this ability at some point as adults, and they can actually complain of the sudden onset of diplopia. Now, you also know that there is a maneuver such that you want to see if the patient can tilt their head towards the side of the fourth nerve palsy to see if they can correct the diplopia, and if that does, then that is your diagnosis or localization. Sixth nerve palsies, or a horizontal nystagmus worse in a lateral gaze of direction, at times is a false localizing sign, since either increased intracranial pressure or decreased intracranial pressure can result in a sixth nerve palsy. It's also underappreciated, let's say, that there are sympathetic fibers that run on the sixth cranial nerve for a few millimeters, so that if you have a sixth nerve and a Horner's on that side, the lesion's clearly within the cavernous sinus, and then the adjacent structures to the nucleus of the sixth nerve include the red nucleus and cranial nerves 7 and 8, so that if you see those associated features, such as nystagmus or ataxia, that would also be very helpful in localizing to that area of the brainstem. Now, of course, there are several other causes of diplopia besides just having a isolated oculomotor nerve dysfunction, and some of the other considerations include orbital disease, which is present at times with thyroid disease, or there can be idiopathic inflammation or a so-called Tolosa-Hunt syndrome, or a tumor in that area. One of the clues that you may be dealing with orbital disease could be the presence of proptosis, which might be noticeable when observing the patient from the side. And finally, there may be some entrapment of one of the oculomotor muscles by an orbital fracture, and the way to test for that is what's called a forced duction test, in which you first anesthetize the eye, the conjunctiva, and afterwards you take a Q-tip or a forceps, if you're an ophthalmologist, and attempt to move the eye. And if you can't move the eye passively, then that would be indicative of some sort of entrapment. And no discussion about diplopia would be complete if the condition of myasthenia gravis was not mentioned, such that on history you would ask about the presence or absence of variability of symptoms, such that there may be diplopia at a specific time of the day, particularly later in the afternoon, or after the patient has become fatigued, or after they've been reading for a long time. And the patient might also notice that the orientation of the diplopia changes. So at times it might be a vertical diplopia, other times horizontal. So those types of variabilities may be suggestive of a neuromuscular disorder. On examination, you're looking for fatigability of both the eyelids as well as vertical eye movements after 1 to 2 minutes of up gaze. And finally, you can see whether or not there might be an oculomotor weakness on one side, and if there's orbicularis oculi weakness on the other side, that's highly suggestive that it is in fact myasthenia. And that gets tested by having the patient forcibly close their eyes as hard as they can and see whether or not you can take 2 fingers and open up that palpebral fissure. If you see that you can do that to the extent that the patient is showing the Bell's phenomenon, in other words, their eyes are rolling up in their head, which is a normal response, that's certainly indicative of weakness of those muscles, and again, very suggestive that this is a myasthenic process. And finally, I mentioned strabismus, which is some sort of almost mysterious condition in which there is a congenital generalized problem of neuromuscular eye movement control, and you could get a hint that that's the problem causing the misalignment of the eyes if there is in fact a history that there was either eye muscle surgery or patching and exercises and therapy when patients in childhood, and at times the adults can have decompensation of an underlying strabismus which presents with double vision.